there is kind of the more recent data that came out of, in the last couple of months in between, AUA and ASCO is the CREST trial, as well as the Sunrise 1 cohort 4, which is the papillary disease. But can you just give us, to start, a little bit of background on the CREST trial, which is, the sasanlimab, which is the subcutaneous PD-1 inhibitor, and how you think this would kind of fit into a urologist perspective here?
Yeah, absolutely. So, immunotherapy obviously has taken the whole field of oncology in a great direction. We've seen a lot of great benefit for patients in all different cancers. Um, and when that was first being seen, there was a few big clinical trials that were designed looking to see if a checkpoint inhibitor combined with BCG would boost the response of BCG.
Right.
Logic being BCGs in immunotherapy, a checkpoint inhibitor is going to boost the efficacy of that. So CREST is one of those several trials that, like you said, combines sasanlimab, which is a IM checkpoint inhibitor, unique. Most of them are IV, along
You're
with
right.
BCG. So this is a nice big trial, well powered. It had good control arms, basically a little over 1,000 patients. It had three arms. One was BCG plus the checkpoint inhibitor, and that was BCG with 2 years of maintenance. Another arm, arm B, was BCG with the sub-Q agent without maintenance. And then
Right.
arm C was just BCG induction plus maintenance.
Right.
And the primary outcome that they were looking for was difference in event-free survival between arm A and arm C. So again,
Right.
you're looking at BCG plus maintenance plus or minus the checkpoint inhibitor.
Yeah. I mean, I think they didn't really see, and they didn't go into very much detail without maintenance therapy. They said essentially that's something that we're not going to really evaluate. They want to just focus mainly on the induction therapy, right? That's
Yes, yes.
and full standard of care therapy.
So really well powered. It was a little over 350 patients in each of these arms, and nice follow-up because they had more than 3-year follow-up for their primary endpoint. And when they compared event-free survival between arm A and arm C, they found a significant difference in the event-free survival between groups, with the combination regimen of BCG plus a checkpoint inhibitor
Right.
being significantly better. The absolute difference, in my opinion, was not massive. It was about a 7% difference between the arms at 3 years. But it was still significantly different, especially with such a large population. When you look at the adverse event profile, kind of as expected, we did see more grade 3 or greater adverse events with the combination regimen. So the BCG monotherapy had 1.4% of patients have a treatment-related serious adverse event versus 17% in the combination arm. So that's a substantial difference there.
Yeah. Yeah.
And when you substratify the efficacy based on pathologic characteristics and other demographic characteristics, the main benefits were seen in younger patients, patients with CIS, or patients with T1 disease. So basically, high-risk characteristics in a younger patient, they saw more
Yes.
difference in response. Specifically, when you look at the CIS cohort, there was a big difference, 92% in the combination for recurrence-free survival at 3 years versus 67%. So you're really seeing a nice accent in the CIS population.
Yeah. Which is where we see a lot of the signal in a lot of these trials, right? Is in the CIS high risk population. Seems to be where we're getting the biggest benefit when we talk about using new therapies.